Good evening, everyone. We're going to be getting started in a few minutes. Just waiting on a few others to join and our speaker for the evening. So just bear with us for a few minutes, please. Thank you. Good evening, everyone. Hope you all are doing well. We are just giving a few persons a chance to get logged on. How's everybody managing with all the rain? I hope nobody's in any flood zones or having any other issues. Everybody's safe?
I am well. Thank
That's
God.
good. Yeah, seeing so many pictures of people in flood zones and other problems. A lot to be thankful for, huh?
Hello, I'm fine. Hello,
That's
everyone.
good. Hi, Dr. Bloomfield. Nice to have you on. Welcome.
Happy to be with you all. Ready to listen.
Yes, we are all anxious. That's why we're just giving a few persons who said they wanted to join a chance to get online before we get started. Anyone have a good joke they want to share while we're waiting? No joke tellers? Oh. Okay, we're gonna.
I guess no joke tellers today.
I guess it's that you're up then, Erin.
I don't know any joke. You put me on the spot.
Just teasing. Okay. Well, we're gonna get started in a few minutes anyway, and I guess hopefully by the time we get to the speaker, those latecomers will be on after we go through all of the announcements and so forth. So again, welcome everyone, and thank you for joining us. This is a big month in the life of the Cancer Society. As you all know, it's Breast Cancer Awareness Month. This is when we see everybody wearing the pinks and all the sales of everything you can imagine pink happens this month. So lots of activity out there. Hope you all are wearing your shirts or your pink, something pink every Friday at least for the month, throughout the month. So we're going to get started now with our prayer. You all can bow your heads. Heavenly Father, we ask for your guidance and wisdom as we gather today. May our hearts be open to listen and our minds be clear to communicate. Fill us with your grace, Lord God, and continue to remind us that all that we do for the Cancer Society and all that we accomplish is for the service of humanity. In your name we pray. Amen. Once again, welcome to everyone. Thank you for joining us this evening. Have a very, hopefully a nice interactive meeting in the Department of Radiology, where she served for 2 years. During this time, she discovered her passion for diagnostic radiology and subsequently pursued specialty training at the prestigious University of the Witwatersrand, I hope I got that right, in Johannesburg, South Africa. In 2019, she returned home to the Bahamas as a consultant radiologist and currently serves as the head of the Department of Diagnostic Radiology at the Princess Margaret Hospital. In addition to her leadership in the public sector, she and her husband, Dr. Minnis, an orthopedic surgeon, launched their joint private practice, Sunshine Medical Center, in January of this year. Their union has been blessed with 2 beautiful children, Noah and Chloe. For Dr. Minnis, medicine is more than a profession, it's a ministry. She views every patient interaction as an opportunity to extend compassion, provide healing, and reflect the love of Christ. Her commitment to building God's kingdom fuels her passion for the lives she encounters daily, reminding her that her calling extends beyond diagnosis and treatment to making an eternal impact. A lifelong member of the Church of God, Dr. Minnis continues to serve faithfully, giving back to her church and community whenever she can. So her presence with us here tonight is quite timely in that Dr. Minnis would probably be reviewing many of the hundreds of millions of, maybe not millions, but tons of mammograms that are taken during this month, Breast Cancer Awareness Month, and throughout the year. So without any further ado, Dr. Minnis, I'll turn it over to you. And can you also make sure to share with us where your practice is located?
Sure. Good evening, everyone. I hope you can hear me, and please let me know if I'm stable. I'm seeing my internet do something here.
So far, so good.
I will share my screen now. Another internet. Are we able to see my screen?
Not yet. At least I can't. Can anyone see it?
Not yet. Oh,
No, we can't.
Okay.
now.
Not yet.
Are we able to
Okay, looks
see
like it's coming.
now?
It's coming. It says it started.
Yeah.
There you go.
All about
Okay,
the
it says
boobs.
participants can now see. Okay, great.
All about the
Okay,
boobs.
so yes, this is a presentation that I started doing for maybe 2 or 3 years now because I realized that a lot of people do not know who their radiologist is. They all know who their referring physicians are, their primary care doctor, but nobody really knows who's the name at the bottom of that paper that is sent to your physician. And also, I'm usually the one, or whoever the radiologist is, the one that's saying, okay, we need you to come back. We need to do another view. We need to do an ultrasound. And so I started to go around and explain to people from my perspective what it is that I see, why we call you back, what we might call you back for, and just to give an idea of my perspective of how we view mammograms. And hopefully it will be insightful to everyone on the call because I know we've heard so much about breast cancer, but just from my perspective, from behind the screen, what I see. So I always start about what the boobs are really made of, and I stole this diagram from the Know Your Lemons organization. They go around and they use lemons to describe the parts of the breast. And I love this because it's pretty much what I see on a mammogram as well. And so I'll use my mouse and hopefully you can see it. So when a lemon is cut in half, the outside of it, the rind, is usually the skin. And then there's a nipple. And then within the lemon itself, there's this area called the pulp, which is usually the fat in the breast. And then there are these white rind lines that go through the lemon, and those are the fibroglandular tissue. And why I like this is because I want to explain what I see on a mammogram. And so just like a lemon, like I explained, I look at the nipple here. The pulp in the lemon is usually this dark area in the back here, which is the fat. And the rinds, which is the fibroglandular tissue, is what I see here, and they appear white on the mammogram. And why is this important to me? And like I like to explain to patients. So everyone has heard about density. Some people say, oh, I have dense breasts. I'm sure you've heard you had dense breasts before, or fatty breasts. So you've had to come back or do more because you have dense breasts. What does that really mean for a radiologist? And so the more of these white normal areas that you have in your breast, the denser you are. So as you can see over here, D, if you're a type A, on the left-hand side of the screen, you have more dark fatty areas on your mammogram than you do the normal white areas. And if you have a type C or a type C, you have way more of this. And why is that important? When I look at a mammogram, anything that is abnormal that's going to show up on your mammogram is going to be white, just like this mass that we're seeing here. So we can clearly see this. But imagine you had breasts like this down here at D. imagine you had a small cancer about the size of this one at the top right-hand side of the screen that was hiding under all of your normal white breast tissue, right? And so I like to explain this to people because a lot of times, if you're younger or just generally have denser breasts, these lesions can hide much easier than someone who has a more type A or fatty breast tissue. And so what you might have to come back and do, because I probably will call you back either to do a squat compression or we will call you back to do an ultrasound to make sure we're not missing something underneath your normal white tissue that we see on a mammogram. And so again, just another example. In a fatty breast, which is on the left, you'll see we have more of the dark fatty area, but we pick a little small area, and then more that easy carefully looking through, or you don't have a high level of suspicion to call the patient back to do an ultrasound or a squat compression to squish out some of that tissue and see it a little bit better. And so a question I get a lot as well is, if I have dense breasts and you're going to call me back for an ultrasound anyway, why should I get the mammogram first? Why can't I just jump over the mammogram and go straight to the ultrasound? So on any mammogram, one of the things that show up very white on the mammogram, and I hope you can see clearly, I've circled it in red, are these little very suspicious on a mammogram. These small calcifications, we won't necessarily pick them up on the ultrasound. And so I like to always start with the baseline mammogram to ensure we don't miss these suspicious calcifications, no matter how dense you are, so that we can have a higher index of suspicion if we see those before going on to the ultrasound. Because if we see these and then we don't see a lesion on an ultrasound, suspicious, even though I don't see a mass on an ultrasound. I hope I'm clear. So I like to go over a couple of signs of breast cancer that I want people to be aware of. And I use the Know Your Lemons crate of lemons as well. I'm stealing from the presentation. It's so impactful. They use a crate of lemons because there are 12. So one of them is if you're feeling a thick area in a particular part of your breast that wasn't there before, that's something that you might want to get checked. If you're seeing a new dimple in your breast that wasn't there before. So if you look over your head and you see one part of the skin doesn't lift with the rest and it's dimpling in, that's concerning. You want to go and get that checked to make sure something underneath isn't dragging it down. If there's crusting or any crusting of the nipple itself that wasn't there before, you want to get that checked. If the breast seems red or hot, and that's not that's a new thing for you, you want to get that checked. And even if it's red or hot, and a lot of times women that have red or hot breasts, they get treated for inflammation or infection. And if the physician doesn't have a high or a low threshold, for this could be something else, we've treated this for 3 weeks, it's still red, it's still hot, the inflammation went down a little bit, but it's not resolved. Sometimes inflammatory breast cancer can be missed because we don't have a low level of low threshold for picking it up. If you have new fluid coming from the breast, sometimes women that breastfed before can have milk discharge for a number of years. We're not really talking about that. We're talking about a new discharge. So whether it's bloody or green or brown, something that's abnormal for you, you want to get that checked. If you have a skin sore that's not healing properly, something you want to get checked. maybe just a bump, and it could be a bite, but if it's something that's not going away, it's not normal for you, it's been there a couple of weeks, get it checked. Seeing a new vein growing on the surface of the skin can also be a sign that something underneath is growing. So cancer needs blood to grow, and sometimes a new surface vein forming on the breast can be cause for concern. A sunken nipple. Some women have naturally inverted nipples that's been there from they know themselves. We're not talking about that. We're talking about if your nipples always stuck out and all of a sudden one winks in, that's cause for concern. You want to get that checked because something may be underneath there pulling it in. If one of the breast size is bigger than the other, and that's not your normal, it's become bigger over some time, you want to get that checked. If you have orange peel skin where there's inflammation, and it's what we call peau d'orange in medical terms, but it basically looks like an orange skin with little dots in it, that can be a cause that something underneath is causing inflammation. And of course, if you feel a hard lump, you want to be concerned about that as well. I usually bring to the attention that we don't see pain on this list. And I bring that to a lot of people's attention because a lot of people, well, not a lot, but there are some women that will see some of these signs and not feel pain right away and not be concerned about it. Because pain isn't always the first sign or thing that happens. It can happen with time. And so I always encourage people, don't wait for the pain to come if you're experiencing one of these things, because by that time, it means it's been there for a while. Just a little bit on risk factors. There are some risk factors that we can control, and then there are some risk factors, obviously, that we can't control. With the ones that we can't control, that was genetic mutations, like the BRCA1 and 2 genes, family history of cancer, so family history of breast, ovarian, especially in your mother or sister. If you've had radiation to the chest for a previous pathology, this can be a predisposition to developing cancer in the breast. Your menstrual history, early menstrual periods starting before the age of 12, and menopause starting after 55 can expose the women to years of unopposed estrogen, and they say that can be a risk factor as well. And then dense breast tissue, it can make it difficult for them to see. It doesn't mean that women with dense breasts just have a naturally increased rate. It's just that women with dense breasts, they tend to get missed a lot more because of what I explained to you before about the normal white tissue and cancers being able to hide in that normal white tissue. And then risk factors that you can control: exercise. 30 minutes of exercise a day has been shown to decrease the incidence. I think this has something to do with the BMI. They said fat cells can produce estrogen. And so for every 11 pounds gained after menopause, they say breast cancer risk can increase by about 3%. Alcohol consumption, hormone replacement therapy, and then reproductive history. So if you've not breastfed, and having children after the age of 30 also does increase your risk. So when should I start doing a mammogram and how often? So according to the American College of Radiologists, for women who are at an average risk, you should begin screening with mammograms at age 40. For women who have a higher risk, meaning you have a gene mutation in your family or you have a lifetime risk of getting cancer of 20% over time, or you've had some radiation therapy to the chest area for a previous cancer, they advise that you begin screening a little bit earlier. They've advised that women can start from age 25 doing MRIs, and then when they get to age 40, they can begin doing their mammograms. I've also seen where if your mom or sister was diagnosed at a particular age, you should actually start screening about 10 years prior. So in my case, my mom was diagnosed in mid-40s. I've started screening in my mid-30s, late 30s. What should you expect? And so if you've all had mammograms before, when you come in, this is what's important to the radiologist. There's always a form for you to fill out, and a lot of women tend to brush over this form, but it's quite important for me as the radiologist. So filling out your normal demographics is fine, but there's always a chart here that has left or right breast. If you have a mole, if you have a mark, if you have a keloid, anything that's on the surface of your breast, it's important to put that mark on this actual chart. If you've had a mastectomy or if you've had a biopsy and there's a scar there, this is the chart that you should fill out and fill out accurately, because on a mammogram, a scar, a mole, a keloid, those things can actually look like it's in the breast, depending on if it's 2D or 3D. And it can increase your risk of getting called back. But if I'm able to go back to this form, look there and see, okay, she's marked, there's a scar, there's a mole, it does help me in my evaluation, and it may limit the callbacks that you get. Noting where you've had your previous mammograms done is also important. I always look at that. If you've had your mammograms done in a different institution and I need to correlate, instead of calling you back, if I know where you've done it before, I may be able to pick up the phone. Can I get the previous for this? It does help me a lot. Putting your symptoms there as well that may not be on the requisition form, but you see some other symptoms. Sometimes they have areas that you can circle. It's important to fill that out to detail, because I always look at this form and it helps me with what I'm going to write. It helps me with how I'm going to call you back if I need to call you back. And so as we know, if you've been doing them, you're going to get the top to bottom view, which is the CC view, and then you're going to get the lateral view, which is the MLO view on both sides. And if you're getting a 2D, it's just 4 pictures. If you're getting 3D, they're going to do a couple of shoots through both of those views so that I'm able to scroll through. Not to get into the argument of 2D or 3D all the time. And I always try to encourage people, if the institution that you're comfortable with only has 2D, 2D is still acceptable worldwide for screening mammograms. What 3D does, allows for me to scroll through a few images, and then I may decrease my callback. I may not call you back in for a spot compression because I can scroll through it, or I may not call you back for an ultrasound because I can scroll through it. But either one, we still do our due diligence. We're still going to pick up on things. It just reduces your callback sometimes at the end of the day. So as a radiologist, I like for women now to be aware of what is actually going to be on your report, and I go through those details. Knowing what your breast density is, it's going to say if you're an A, a B, a C, or a D. It's going to describe the abnormalities. Is it normal? Is it benign? Is it suspicious? And then it's going to give you a number. And I always like to bring special attention to this, because most women have done mammograms for years and years and years and don't know that there's a number at the bottom of the report on every single report, and it tells you exactly what you need to know about that report. And it goes from 0 to 6. I always tell patients, know what that number is, know what your BI-RADS number is, because even if you cannot remember what the wording was on your report, if you say that you were a 0 or 1 or 2 or 3 last year, your physician should know, okay, she was a 2, it means they saw something in another year. And you don't have to remember all the time. You may not remember all the words, but if you remember the number, it will help. So a 0 means we need to do something else, meaning either you have dense breasts or we saw an area that we're a bit concerned about. We'll call you back maybe to do a little magnification view or an ultrasound. And once you come back and get those further investigations done, we will convert that to another number. If you're 1, it means everything is normal and we see you again next year. If you are a 2, it means we found something, but the features on the mammogram and the ultrasound are not suspicious. They're benign. We're not concerned about it. We just need to note that it's there for when you do follow-up mammograms. And so we give you a 2 and your return is in a year. 3 means that you're probably benign. We don't think it's really suspicious, but we don't want to wait a year. We want to follow it up and make sure it's stable. So we give you a 3 and ask you to come back in either 3 months or 6 months. And once it's stable, we'll probably convert you to a 2. But if it does progress or it looks like it's growing in size, we would probably convert you up to something more suspicious. Okay. If you're a 4, 5, or 6, it just means degree of suspicion that we have, but all of those numbers require a biopsy. So if you go to your physician and you don't remember anything, but you remember you were a 4 or 5, it means, hey, you should have had a biopsy because the report had requested that. If they say you were a 3, okay, I should have had a follow-up in about 3 or 6 months. Did I go and do that? Did you go and have that, right? And if you were a 0, did you go and do the further investigations that they asked you to do? So every woman, I always try to say, please remember that number if you don't remember anything else. Monthly self-examinations. I try to encourage women to do them same time every month, beginning of the month, middle of the month, end of the month. Try to do it at the same time. You can do it, partner can do it. Just make sure it's something that's done monthly so that you know what your breast feels like. And I usually do this little quiz. It's also from Know Your Lemons. What size lump would you find if you were just on accident, taking a shower or just randomly, you're putting on your clothes and, oh, I feel something. And I usually ask this question. I can open it up, or anybody want to take a guess which size they think would be the size that you would find on accident? Meaning you're not doing swimming mammograms, you're not doing monthlies, you just happen to find a lump in the shower.
Would that be A?
Right, you're right. So A is actually the size that they say most persons find accidentally on average. It's actually the largest size, right? Because most people are not feeling their breasts regularly. And so you're not even noticing that this thing is growing until it's to a point where you're feeling weight to it or you felt something accidentally. The size that you would find on routine examination is B. And so if you know what your breasts feel like, you know the normal lumps and bumps, you can actually pick up these sizes much smaller than if you were just accidentally, feeling your breasts one day. And size C is the size that we can find just as the tip of your index finger if you're doing your yearly mammogram screenings. Right? So a little bit on biopsies because that's what the topic was about. If they find something suspicious, meaning on your mammogram or your ultrasound, most times if they find a suspicious finding on your mammogram, we're going to call you to do an ultrasound. If we're able to see the same suspicious finding on the ultrasound, we'll go towards doing an ultrasound guided biopsy. We usually do them on either palpable masses, meaning you can feel them, but a lot of times the surgeons will still send them for ultrasound guidance to make sure we're getting a good sample, make sure we're not getting the necrotic area that's not going to give us good tissue. And so we use the ultrasound machine to look at where we're going in the mass. And then masses that are seen on ultrasound. So you're not able to feel it, but we did pick it up on the ultrasound. We will do it ultrasound guided. Mammogram guided. I go back to those small calcifications that we saw on the mammogram. Sometimes you see these calcifications, but able to we send you back on the mammogram machine. We target and plot a core sample of those calcifications to send them off to the lab. And then the other types of biopsies that we would do, like I said, we did mammogram guided, CT guided, or that's supposed to be MRI guided, sorry. So if we saw something suspicious on the mammogram, didn't really see anything too suspicious on the ultrasound, and you happen to go and get an MRI done, whatever modality was best picking up that abnormality is usually the modality that should be used to get the sample. So if it wasn't seen that well on mammogram or ultrasound, you wouldn't utilize that modality. You would stick to the modality that picked up the abnormality the best. And then, of course, an excisional biopsy. A lot of times, sometimes younger women would just opt to have it taken out, the whole thing. If it's mildly suspicious, they just want to have it taken out. And if it's palpable, the surgeon will just take it out. If it's not a palpable thing, you would come to the radiologist. We would put a wire in, and then the surgeon will localize it like that. And so that's the end of my presentation. And I open the floor to any questions to me. And I hope it was insightful and a little different perspective from what you've heard before.
Yes, thank you. It certainly was. I certainly have never seen a presentation like this before, and it opened up a lot of it provided a lot of information for me, because I'm one of those people who has to do an ultrasound along with the mammogram, and I guess now I kind of understand better why, having seen the pictures, it makes a lot of sense. But I do have a question. I think you might have touched on it. So how important, I guess, is it that you always do the mammograms the same place, or, as opposed to moving from one place to another?
Right. So I always encourage people, once you're comfortable, sometimes people, doing a mammogram is quite an intimate thing. And women want to be comfortable. Women want to know, care is being taken. They don't want to feel rushed. They don't want to feel shoved into a room and there isn't much privacy. So I always say, first of all, be comfortable where you're at. If you're comfortable at the institution that you're doing your mammogram at, I say try to stay there for 3 to 4 years. That's just my opinion. Try to stay there so that we can see sequential changes. Because a lot of times, if you did it last year, then you jump to another institution did last year. And so something that was found last year, we did an ultrasound last year. We called it benign. We've set it to 2. Next year, if you go to that same institution, they're not going to work that up again. But if you jump to another institution and they're not able to see your previous, or didn't take the due diligence to look at the previous, and a lot of institutions don't have the ability to cross and look at other things. I've worked at a number of institutions, so if I know I'm able to access the mammogram from one institution to the next, I will certainly make sure that I look. But not all institutions are able to do that. And so I always encourage people to try to stay to one institution for at least 3 to 4 years so you can see sequential changes, and the radiologist can pick up sequential changes right in that moment. Okay, because sometimes you jump and they don't compare from the institution, then you end up redoing this workup for something that the other institution has already called benign, because I don't know if that's changed size from last year to this year. So I think try to stay if you're comfortable.
Okay, thank you.
Yes. A lot of times persons would say, well, I've never felt a pain in my breast when they've been diagnosed. And I always said, cancer in its early stage, you won't feel any pain until it and so getting a mammogram done early, is the best course of action to catch it in its early stages. Because once you wait until you, like you say, feel pain, and the crate with the lemons, the dozen lemons, when you start having those things, then it's reached to a very serious stage. So, encourage women, get your mammograms done regardless if you feel no pain or you don't have any symptoms, because, it can be very small and can catch it in its early stages.
Yes,
I just want
100%. I agree. Yeah, I try. Breast pain is very common amongst women, and it might be one of the top things I see on a breast ultrasound form, particularly in younger women. And so I still advise it to be checked if you have pain, even if you don't have the signs that I said. But being I usually try to give them some awareness, because there are a number of things that can cause breast pain. It could be hormonal, caffeine, chocolate, stress. A lot of things can cause breast pain. And so when you have it, come in, get it checked. But if everything else checks out, a bit of counseling as to what can cause breast pain also helps to alleviate some of a woman's anxiety around it, but also giving them other signs to look for. So, yes, if you're having this pain, but now if you see this, now if you see this, now if you see this, now you know what to look out for.
Did you say chocolate?
Yeah, you can.
Did you say caffeine?
Oh my God.
Definitely caffeine. Because one of the things when you're looking up, they ask you what to do when you're not. It just, I think because it's a stimulant. Yeah, it does affect the breast in some ways. Yeah.
Okay. Um,
And
I
we
want
advise you not to have it before your mammograms and stuff like that. Yeah. Especially
okay.
if you have sensitive, yeah.
Okay, that's a good thing to know.
yeah, I'd like to chime in, follow up to
Sure.
what Dr. Minnis said about where to get your mammograms. I think one of the things that people need to, everything that you said, Dr. Minnis, I agree with. But another important thing is often people get ultrasounds or mammograms done, and the report never gets to the physician, even though the place doing it promised that they would send them. So if you get a reliable organization or medical facility that is good at returning your report, I think you should stick to that. The other thing again is
That's true.
I often tell people in light of looking for breast cancer, pain should probably be way down on the list. Not that it can't occur, but I would look for all the other things that you pointed out in that crate, before I get to pain. Of course, you can't discount pain, but in terms looking for cancer. And it's very important to find early lesions, because if you find early lesions, you often will get a good chance. And so, my own family experience, my sister is now 21 and 11 years respectively with breast cancer. And hers was found before it was detectable by palpation. It was found on a mammogram. The first time they said this lesion wasn't there last year, and we see this small spicule, and it's suspicious. Come and see us in 6 months. Of course, I knew my sister, so I encouraged her to go and get the testing done, and of course she did, and she had breast cancer. And so it's now 21 years later, so she's fine. But I thoroughly enjoyed your presentation.
Yeah. Thank you. Thank you.
We also have a comment in the chat.
And I point out again. Yeah.
Sorry, no, go ahead.
I just want to stick again that women will see these things, and because not just feeling the pain, because it's not painful, they wait. And so that's why I always point out that pain is lower down, because I don't want you to wait for the pain, because these things can happen and you don't actually feel pain. So waiting for the pain is actually the thing I want to strike home. Don't wait for the pain to come, because it's usually way down.
Can I say something, please?
Sure.
I agree with you with that, because my mother was diagnosed with breast cancer during COVID, and she didn't have any pain at all. And so because we were in the COVID season, and we were isolated, we didn't do anything about it. And when she started to have pain is when we went back to the doctor. And when we went back, they said the cancer had already spread. And we also realized that she had had a heart condition. So there was nothing could really do. She was unable to get radiation or chemo. But like you say, don't wait for the pain for you to act. So I agree with that. Another thing that I want to say too is I did not know that on every mammogram report there is a number. I did not know that, so I had to look out for that when I do my mammogram again. That's the first time hearing that. So thank you for that information.
Yeah, yeah.
Well, on that note, I wanted to say that I personally have never seen my mammogram report. My doctor gets it. So I didn't even know that there is a number. I don't know where to look. I've never seen the report that goes to the doctor. Normally, I would have my annual. The doctor would send me for a mammogram. And then they would call back and say, oh, everything came back normal or whatever. I have never seen a report.
Yeah. And so even if you don't see it, because most reports will get sent back, just say, what's my number this year?
Okay,
You
so
know?
that was a good tip. Thank you very much for that.
Yeah,
Mhm.
no problem.
Comment. Usually they would ask your physician and then they would send the report directly to them.
Right.
Is it some way you can ask them to get a copy? Would they?
Yeah.
But I know
for-
with go ahead. Sorry, I have another part to that, but
No,
you
go
answer
ahead.
the part. Yes, with the Cancer Society, we have a FIMS program, which is acronym for Family Island Mammogram Screening, and where we fly in at least 15 women from one of the family islands, and they get a mammogram because they're not from New Providence, and most of them don't have like a private doctor on their island. I know Oak Tree, we've been using Oak Tree for the past several months because of their partnership with the voucher. They would give
Mhm.
them a copy of their report to take back home to their doctor or to the clinic. So now we having one coming up at the end of the month. So I would now really have to relate the information to them about the numbers at the end of their report and
Mhm.
also to speak to their doctor about that in depth because like most persons on this call never really see their report or don't even know about the numbers, or if they see a number they had no clue what it was all about. So that was good knowledge, I mean good information given.
Very good.
Yeah.
In the chat, we have a comment from Dr. Shea. Says, she just switched. Let me see. Sorry. Hi, thanks, Dr. Minnis, for the informative talk. Can you tell the audience the difference with 2D and 3D and 2D and 3D mammograms, and what type of mammogram does your center have?
Okay. So 2D and 3D, I think I touched a little bit in the talk. 2D and 3D, both of them are taken the same way. With both of them, you're going to get a view from top to bottom, and you're also going to get a view from side to end. So a lateral view and a top to bottom view. With the 2D, it's just basically a snapshot, one shot here, one shot here. When they do the 3D, when they do this shot, the machine moves a little bit to give you a couple of slices down through the breast. And so now the pictures that are presented to me, I'm able to scroll down. And then when they do the side, they do the same 2D shot, but then the machine moves and takes a couple of slices this way. And so now when the images come to me, I'm able to scroll through the breast this way and back this way, up and down. So it's almost like a mini CT I'm able to scan through. And so the radiation is a little bit more with the 3D, but still underneath FDA approved. And I always tell people mammogram radiation is 0.4 millisieverts. You get 3 millisieverts of radiation a year just being around. And a mammogram is only basically 7 weeks of your routine day-to-day radiation that you will get, right? So even if it's 2D or 3D, you're still within 0.4 millisieverts of radiation. Okay, so not that significant more radiation. What it does do is it helps the callbacks. So if I'm able to scroll through and I can see that, okay, this thing is on the surface and not in the breast because it's at the top slice and not through the middle. Maybe this is a mole. Let me look back at the chart. Did she write a mole there? It helps me in that. Also, it helps me to scroll through denser tissue. So I may not call you back for a spot compression because now I can scroll through. So it does eliminate some of my callbacks. But like I say again, we still do the due diligence with the 2D, even if, we're not able to scroll through. And so that's the biggest difference. It's just my ability to scroll through. It's helpful for people with dense breasts who have a lot of that white tissue that I need to scroll through. And my center at the moment does not have mammogram, but it is coming. And I am going to get a 3D. I do have in my mind a plan that I have for my mammogram machine that I hopefully, when it's in place, I can share what I want to do with that machine that I think will be helpful throughout the Bahamas. But coming soon. Yeah. And my center is in Palmdale. Palmdale Avenue is the corner where Wendy's is off Mackey Street. Mm-hmm. That's Palmdale Avenue. And we're right through there next to where the old Mount Carmel School used to be. So it's on the right-hand side,
yes,
diagonally across from Kemp's Funeral Home.
Yeah. Okay.
Mm-hmm.
We have also a comment from Alinda Bow. She says, as a breast cancer patient, please get copies of your reports, names of medications, and names of treatment, because you need to be your own patient advocate. And that also is very good advice.
Yeah.
Okay.
And what I tell people, if you move from one center to the next, give the facility a previous report, or if you have them, because they can be scanned into the system. So at the very least, even if I'm not able to see the image, I'm able to see the report. And I can at least say, okay, they mentioned this last year, it was this size. They mentioned it the year before. So now that it's this size this year, I can probably say that this is a stable thing because I can see the previous report. So even if you don't have the images, carry the reports with you. Tell them, can you scan this into my file for the radiologist to see? And then you keep your copy.
Okay.
Can you let us have an idea what percentage of women who require mammograms actually get them done in the normal population versus somebody who actually has a suspicious lump or some reason indicating that something may be wrong in the breast? Because in my experience, what I find is that a lot of people are not getting screened. They often show up when they suspect something is going wrong.
I don't have that percentage in my head, but I will share something that troubles me, because the mammogram at PMH has been down for a number of years. And I shared a statistic when in February, I put together with MD Anderson and PAHO, they came down and they trained just about every institution in the Bahamas had one or two radiographers there getting their training for mammograms. And what I shared with them at that time was, even though we did not have mammogram last year, I still did about 65 biopsies. That's just me. And about 30 something of those came back positive. And why I shared that is because this is not 65 women who I saw a mammogram of at PMH and it's a small thing. They didn't feel it, but I picked it up. These are people that felt it and decided to come, or was sent by someone because now it's a particular size, or had the money to go and do it somewhere else and couldn't wait for PMH to be up. So even having not screened all of last year, 65 women still came to the door for biopsies, you know, so I don't know what that number is, but I don't believe people are screening as much. People wait until they feel or the physician has felt something and sent them in.
And this is exactly what the point I'm making, that a lot of time people come when there's something going on. It's not there's a joke. I see people annually every 5 years.
Yeah.
So it's not going to work.
Yeah.
So the other thing for the people, I've never really given a number, the Byrod's number to patients, but the suggestion that the report was normal, you repeat it annually, which indicates is 1 to 2. If I call you in, sure, you need to have this repeated, you need a additional ultrasound, then that represents a 3. And of course, biopsies, I send them for biopsies every chance I get. No matter how small that lesion is perceived to be, because especially when you get the history. So that's what it is. But I will start giving out the numbers now.
Because 1 and 2 is fine, but most women cannot remember that I needed to follow. Why did I need to follow up? They don't remember the wording. But if you, as the physician, ask them, well, what was it? And they say it was a 3. Your next thing should be, okay, did you do the 3-month or 6-month follow-up? Just knowing that they were 3, because they may not have seen you. They may have had a mammogram done somewhere else, but I encourage them to know, were you a 3? Were you a 1? Were you a 2? So that if you move to another physician, you can say, well, I don't remember what it said, but I was a 3. Okay, now, did you do the follow-up ultrasound? You know what I mean? Did you do the biopsy if you were a 4 or 5?
Well, that was my teaching lesson for tonight. I'm going to start giving out the numbers. Thanks very much.
Somebody in the chat is asking, Yolanda is asking, what do you think is causing the increase in breast cancer in African Americans?
Maybe Dr. Bloomfield. They've almost classified Black as higher risk, period, along with the Ashkenazi Jews, just because we have a higher rate of the triple negative. We tend to have more of the gene. I don't know what other environmental factors tend to affect us more than any other race, but those two are one of the things that tend to put us in a higher risk category.
I would say obesity is probably in that category.
That's a part of it too. Because like I said, they said every 11 pounds post-menopause increases your risk by 3%.
That was eye-opening as well. Wow. Because so many people put on so much weight after menopause. That's very concerning. Oh, as if menopause isn't stressful enough.
And also stress.
Oh my goodness. Oh,
Good evening. A question, please. I heard the reference to the number that comes with your results for your mammogram. Does this number have a specific name, or do you just ask to have your...
It's called the BI-RADS. It's called the BI-RADS number. BI-RADS, BIRAD. Yeah.
Okay. Thank you so much. It's always good to sound intelligent when you're speaking to your doctors or any of your physicians of that nature. So thank you so much for that.
And truth be told, when you ask for the BI-RADS, because I'm also still trying to get the doctors to say it to their patients, some of them might be like, oh, let me look, because they may just go to the impression. But no, I try to encourage them, give out the number, because it's universal. If you take that number from here to the States, it means the same thing.
Okay. Thank you.
That is good information. Anyone else have any questions for Dr. Minnis? Comments? Anyone want to share experiences? Do we have any survivors out there want to share their story, their journey, any aspect of it, the testing, screening? We'd love to hear from you.
And don't be shy. Well, I'll start. I usually get my mammogram every year, and I didn't feel anything different. I didn't feel a lump. But they saw one, and I had to do an ultrasound with a biopsy, and it came back positive. It was small. They had it at stage 1, so it was in its early stages. Um, I
They
had
give you your BIRAD number?
I I no, I didn't know what my BIRAD was then. Wonder if I still have that result. I better go look that up.
Mhm.
And Linda say, keep records. I think I may have my record. Yeah, so it was stage 1. I opt to have a lumpectomy. And Dr. Shea was my surgeon, and he removed a lymph node from under my arm, and there were traces of it, so it moved from a stage 1 now into a stage 2. So, that can tell you that, like the lady said about her mom, I think Yolanda, like you delay and having treatment, this thing can spread, and you don't feel it in your body until I guess it gets all through and you start feeling the pain. So sometimes, women would say, well, I don't like to have a mammogram done because, they squish the breast and it hurts. And I always encourage them, I said, it's just a few seconds of discomfort, just a few seconds of discomfort, but knowing that you're okay, knowing that, there's nothing going on in the breast that you can't feel is good. It's a good feeling to know. But if you afraid of the mammogram machine and refuse to go, even if you feel something in your breast, but you still refuse to go, it's like you signing your own death certificate. That's how I look at it, because there's something wrong, there's something abnormal, but then you just refuse. You like stick your head in the sand like an ostrich and hope that it goes away, which it will not. We still have a few mammograms, vouchers for free mammograms. And, those that can't afford one and need to have one done, you can come at the Cancer Society and have a voucher to have a mammogram done at Oak Tree Medical. I know Dr. Minnis had said, try to stick with the same facility. But if you haven't had one done in 2 years, 3 years, just get it done. Just get it done and, feel comfortable that, you're not in that statistics of being diagnosed with breast cancer. But I've seen a few persons on the Zoom meeting here that I know that went through and would like to share their story. Not all stories are the same, may be diagnosed with breast cancer. Some caught it in very early stage, some in the later, but yet um, it has been successful with their treatments and, could say they're in remission. So, ladies, come on. You don't have to put your camera on, but you can tell your story on how you were diagnosed. We'd like to hear from you.
Good evening, everyone. My name is Anna Mae Dorset, and 3 years ago, well, 3 years ago, September, I had a mammogram, and it came back with non-invasive. It was diagnosed as non-invasive breast cancer. I had an option to either take it out, a small calcification, I think they called it, or there's 3 options, or have radiation, or remove the breast. But I opted to take them both off. Dr. Francis did it, and I was trying to get, because when I shared my testimony, a lot of people, what stage I was at, and I asked him, he said, there's no stage because you don't have it. When he got his biopsy back, because I went to the walk-in clinic on Shirley Street, they did it. And they were so small, the radiologist, she sent me to him, the surgeon, and he sent me back to her for her to do the biopsy. She was saying it was so small she might have missed it, but she did it and sent it off. And that's when he said non-invasive. And I asked what that was about. He said that it was like you open the gate and the horse right there or something like that to that effect. And it's not going any place. So that was like, and as a matter of fact, I went to the doctor in June because I live in Andros, I'm in Andros. And I went up there to Nassau and I ran out of my high blood pressure pills. So I had to go see a doctor before they could rewrite them, do the refill. And the doctor I went to couldn't, well, she didn't find anything. That was June, late July, or maybe it was early August. I went and my daughter gave me a certificate to go and have a mammogram done. I did it, and that's when they called me in to do the ultrasound. And that's when they saw these small calcification, they call it. And then the radiologist sent me to the doctor, and he sent me back to her. And I had it, like I say, 3 years ago now. And I used to see Dr. Francis every 3 months. Now I see him every 6 months. So according to him, I'm cancer free, and I give God thanks. So that's my story. I'm well. And the only problem I have right now, and I really would hate to believe this, is I kind of used to laugh at my mom when she was saying like how it's so rainy, she would feel painful, or persons talk about having surgery and feeling painful. And I'm feeling that right now. So I don't know what's going on with that. Not
But I have
painful, but a
those
lot
knee
of
pains too.
discomfort. Like discomfort. So that's my story. I'm doing well. I'm doing okay. And I just had the most removed. I'm 75. I think I don't need them anymore.
Wow.
Take them. I'm
Good for
doing
you,
good.
Anime. I'm happy for you that you
Thank
are
you.
doing well.
Thank you so much.
So positive after your experience. So
Yeah.
that's a big
Yeah.
part of it, I guess, too, is your state of mind, eh?
Yes. Didn't feel any
Staying
lump at all. I
positive and
tried to find them. Not a thing. I felt nothing. Like I
Mhm.
said in June when I went to the doctor, she felt nothing, the doctor who did it. And just July, the end of July, the
Wow.
mammogram showed the small calcification. And after that, I tried to feel with these lumps, not a thing. But I'm doing well.
Good for you.
Mhm.
And
I have a
thank you for
question.
sharing. Go ahead, Yolanda.
My mom died with breast cancer 4 years ago, and she had two sisters who both died with breast cancer. Um, what I want to know is from Dr. Minnis is that something that I need to be concerned about? I usually go and get my mammogram and ultrasound done once a year, but is once a year sufficient?
So that is the recommendations over a number of societies. I think ACOG, ACR, RSNA, those are the radiology and the obstetrics and gynecology. That's still the recommendation. I haven't seen anything go down. I have seen them ask for supplemental, meaning if you are high risk,
Mm-hmm.
um, instead of just having your mammogram, they say you can do a supplemental MRI if you're a high risk patient, right? But they don't suggest that you do mammograms twice a year. They just ask you to do a
Okay.
supplemental test, which would be the MRI. And if you cannot have an MRI, then a contrast enhanced mammography, which I don't think anyone here does routinely, but the MRI can be done here. Yeah.
That's in addition to the ultrasound?
That's in addition to your mammogram and ultrasound, if the ultrasound is suggested from the mammogram, yeah. And most breast
Maybe.
MRIs, they do ask to see because as radiologists, we look at everything. So there are some things that are better seen on like calcifications and those types of things are better seen on x-rays and the mammograms. And so they read the mammogram that you've had before on the ultrasound in conjunction with the MRI, and then they come up with a total finding at the end, you know, so it's all to help supplement each other.
Can I add to that?
Okay, thank you.
Yolanda,
Thank you. Yes, sir.
what I would suggest that you never miss your mammogram. Every year.
Yeah, yes,
Make sure
I
you
don't
do that.
miss.
And
I make it my business to
you
do
should
it.
also be a candidate to get screened for the BRCA gene, just as part of your routine. And because you're with the history that you indicate, you definitely at high risk. You may never get breast cancer, but you're at very high risk for it. And I just want to also
May I ask
add,
who
men
does the
to check.
BRCA?
You can get that done at the labs. You can consult with the doctor and they could send you to one of the labs.
Okay, sir. Thank you.
Yeah. But I think it's important. Again, whoever been looking after your family members, they could probably direct you to you want to have continuity of what's going on.
Well,
Also,
I can say this.
yeah.
My mother's oldest sister who
Yeah.
died with breast cancer,
Mm-hmm.
she didn't tell anybody that she had cancer. This was years ago. What happened was her daughter was passing and the bathroom door was open and she looked in and she saw her mom had this hole in her breast where she was packing with tissue.
Yes.
And that's how her daughter found out that she had cancer. And then another one, but she was attending doctor for the breast cancer. And like I said, my mom was unable to do anything because she had underlying issues.
Yeah. Let me share something with the participants tonight. One of the things that I teach when I give my lectures. If you have any elderly relative that you visit from time to time, and when you walk in the house, you smell bleach or perfume, instead of giving them flowers for Mother's Day, take them and let them have a physical exam. You'll be amazed at what you might find. That's coming from my experience in the Bahamas. They hide stuff. Okay? They hide stuff. I've seen, the best and the worst of a lot of these things. So if you smell perfume, if they're always hiding, they're always well dressed and all combed and dressed up when you come to visit, be a little bit suspicious. Because underneath all of that charade, they're hiding something. So I would do that. Another thing, again, I'd also recommend that men also examine themselves, because men can have breast cancer as well. Now, they're asking people to share. Now, I had a lump removed from my breast 3 years ago. Fortunately, it wasn't malignant, it was benign. But I didn't feel it until the night I started having pain. And it was about the size of a pea. So it must have been there all the time, but until it hurt. And again, because I don't get mammograms, I don't, routinely feel my breasts or anything like that. But that was removed and it turned out to be benign. But I had that out in a week. I didn't hesitate to get it done. So, men also need to examine themselves.
Yeah, I was going to say, is there a protocol for breast cancer screening for men? Like I know you say for women after age 40,
No.
What's the protocol for men? Just
no, there's no protocol for
when they
men.
feel something.
There's no protocol for men. I think if you feel a lump, you have to get it ultrasound or biopsy done to see exactly what it is. But there's no routine protocol for men. Men in families at high risk for breast cancer, notable, should be even more vigilant. Self-examination for sure. Yeah. Go ahead, Dr.
I'll
Minnis.
just jump in. There's no protocol, but I agree they should be routinely feeling their chest area so that they know what normal lumps and bumps feel like for them. And what I would say is men that do feel a lump, maybe it's a little extra tissue, and painful, could be what they call gynecomastia. And a lot of times physicians send the gynecomastia for the ultrasound first, and that's fine. And then me as the radiologist, when you look at gynecomastia on an ultrasound, it looks very scary. And I always send them back for because gynecomastia looks like a mass. It has increased color uptake. All of that is happening. And I always send them back for a mammogram because there are distinct features on the mammogram that I'm already like, even if I didn't do the ultrasound, I already it's gynecomastia. But if you get sent for the ultrasound, and I've had it happen a couple of times, maybe 3 times. One time, they had the ultrasound. It was said it was suspicious. The surgeon decided to just do the biopsy, and guess what? It came back as normal breast tissue. And then they sent to me, and I said, "Wait, let's do a mammogram." And I sent them for the mammogram, and it looks like gynecomastia. I already know it's gynecomastia from the mammogram because it has a distinct feature. And it made sense that the reason why the surgeon got back normal breast tissue is because they thought they missed it because it wasn't ultrasound guided, but they got tissue, but it was normal breast tissue because it was gynecomastia. And so I always say there are more distinctive features on mammogram than ultrasound for gynecomastia. And so I will always opt for the mammogram with gynecomastia in men, just to make sure, because if it's a suspicious mass, that's a distinctive feature. If it's gynecomastia, that's a distinctive feature on mammogram. And on ultrasound, they both look scary.
Doctor, are you using this word gynecomastia? Can you
I'm so
explain to
sorry. So gynecomastia is just male breasts. So a lot of time men present with painful breasts, like they start to grow breasts like women, and that's gynecomastia. And it's scary for them because it's painful, and you may even feel a little lump behind the nipple. And a lot of times because they're like, okay, they're men, let's just send them for the ultrasound. They'll get the ultrasound. The ultrasound picks up this dark area with increased flow, and it looks suspicious. If I see it, I'm going to tell them to get the mammogram, and then I'm going to make my decision because as a radiologist, there are distinctive features that I can already see, and it will save them, from having a biopsy for no reason sometimes, you know.
Okay. So gynecomastia is different from men that are overweight and then have like breasts. That's
Yeah,
different. Okay.
yeah.
And when they're overweight and have those kind of breasts, can they also have a mammogram or they just have ultrasound?
What I'd say is you don't know which one is which. You know what I mean?
Mm,
You don't, you're not sure. But if the male is suspicious about
mm,
it, it's painful. There's nothing wrong with starting with the ultrasound, but as a radiologist, I always like them to have the mammogram as well. Yeah, as a
okay.
complete.
Okay.
Mhm.
Anybody else would like to share this story before we wrap up?
Good night. This is Alinda. I'm a stage 4 breast cancer patient. I'm saying patient because I'm still going through. I was diagnosed in December of 2021. Actually, I did my mammogram in November as usual. I did my mammogram every year from since I was 40. I'm now 56. So in December of 2021, I was diagnosed. I did oral treatment first. And when that stopped working, I had a double mastectomy. Dr. Shea was my surgeon. Very, 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 very good surgeon and healthcare provider. And Then I did radiation after that, and then chemotherapy, intravenous chemotherapy, which was working for a while, and then it stopped working. The earlier part of this year, 2025, I had lesions on my skin, on my breast. Well, the skin that's covered what was my breast. And that was in that was November of 2024. And I went to City of Hope in November of 2024. And medication that they gave me, it was worked for about 6 months, 7 months. And just last month, I did a PET scan, and it had spread to my back, and it's no longer in my chest. My chest is all cleared. There's nothing on any organs, any vital organs, lungs, or anything, or heart or anything like that. But it's now on my pelvis. They're still calling it breast cancer, but it's now on my pelvis and my back. I started Doxil, also called the Red Devil, last week. And so far, my only side effects are fatigue and just a very, very odd feeling of tightness. And my chest feels like I have one of those plates that they put on you when you do a mouth x-ray or teeth x-ray. One of those plates. It feels like I have one of those on my chest all the time. But I'm good, otherwise healthy. My mother died in August of last year at 91. And Doctor's Hospital have it listed that she had breast cancer. She's never had any pain, any treatment for breast cancer in her 91 years. 2 years ago, they tested me for the BRCA gene. I don't have the BRCA gene. I have 5 sisters. None of them have any signs of breast cancer, but we encourage each other to go and get a mammogram every year. So I've been up and down. There are good days, there are bad days. Today, when I saw the meeting on, Ms. Gibson usually calls me from the cancer center to say, just to remind you there's a meeting today, but I guess she didn't have notice either, so she didn't remind me. But I saw it probably about 40 minutes ago, so I logged on. But that has been my journey, stage 4. I will go and look on my reports for that number and see what that's another thing that I have to look for. I'm learning a lot. I'm trying to read for myself and try to understand as much as possible what's going on, and not get sucked into the negativity.
Well, I must say, Miss Amanda, congratulations to you. You seem as if you are a fighter, and you have been through a lot, and you are overcoming. And it's a mind over matter thing where you know what you are diagnosed with, but that it doesn't mean that that's the end of your fight. It's just the beginning. And I commend you and I encourage you. And Miss Gibson didn't remind you because yesterday was a holiday. So she only comes in Monday, Wednesdays, and Fridays. So I know if she was there, she would have called and remind you. But know that we're there in the fight with you, and we won't give up.
encourage people to share their stories. It's hard when my mother, and I'm saying this post-mortem, my mother probably was going through pain, but she didn't tell anybody. So hopefully she wasn't, but it's hard for families when they don't know their family history. Thank you very much for listening.
Thank you. Thank
Thank
you.
you very much for sharing, and we keep you in prayers for success through the rest of your journey until you see on the other side for recovery. It's our prayer for you.
All right,
Um,
Ms. Host, do you want to take it over, maybe?
Yep, so we hope everybody enjoyed this session tonight. I think it was very informative. Lots of good information. And so we thank Dr. Minnis for coming on and joining with us tonight and sharing all that very, very good information. And doctors will now be bombarded. What's my number? What's my number? So if we remember nothing else, I think we're all going to remember that. So thank you for that information. And even Dr. Bloomfield took a lesson from that. So that's a great takeaway for you and for us. So we want to thank you again for coming and joining and sharing with us this evening. And for everybody else on the line, we want to say stay positive, stay safe, and next month, do we have a meeting next month, Erin? Yes.
Next month is Men's Health Month.
Yes, that's right.
I know September is normally prostate cancer month for men, but we like to talk about the whole man, not just the prostate, but their mental health and prostate and testicular, the whole man. So join us next month, the second Tuesday of the month, which will be November 11th. 6:30 via Zoom, and listen out and invite your man friend, your husband, your uncle, your brother, your nephew, because it's very, very educational for men to know about their body. They're not like women who, something go wrong, we want to know what's going on. Men like to hide more
Or
than
even to
women.
laugh
So
on it. But that
yeah,
doesn't mean that
so
you ladies can't also be on the call
yes.
next month. It's ladies and men, but we want to try get as many men out as possible. Because if you look at this tonight, I think we have maybe 3 men, so maybe 4. So we would like to have a lot more men come out than usual. So yes, I see. Invite the church men's group. So yes, if everybody can invite the church men's group from their church, hopefully we'll have a good turnout next month. So that's a great idea. Thank you, Yolanda. So thank you all for joining once again. And thank you again to Dr. Minnis. And everybody stay safe, stay dry. Hopefully that we'll get a break from this rain so some of this water can dry up. And we'll see you all next month on this call. And also those of you in Nassau, I'd love to see you out to the Love Lights a Tree when we light up that tree lighting ceremony. So everyone take care, stay safe, and we'll see you soon.
Don't
Take
forget,
care.
bingo
My
night,
pleasure.
Remember
October
that we have
25th.
vouchers for mammograms as well. If you need a voucher, give us a call or come out to the Cancer Society and see Erin. Sorry,
Yes,
Erin.
but
you're
don't
saying-
forget bingo night,
Oh, yes,
25th.
bingo, yes, bingo.
Yes.
All right, thank you,
All right.
everyone. Good night.
Good night.
Good night, good night.
Good night.
Good night, everyone.
Good night.